welcome everyone to the Message webinar and today's launch of the Message Policy Framework. My name is Kate Womersley. I'm the co-principal investigator of the Message Project and an NHS doctor in psychiatry. It's fantastic to see so many people here from different backgrounds, from research, from medical practice, the policy sphere, as well as patients and people with lived experience. We have an inspiring lineup of speakers who are friends and collaborators of Message and have supported its success over the last 2 years. We're also very excited to hear from you, our audience, throughout the webinar. Please do submit your questions through the Q&A function, and thanks to those who've already sent their questions in. Today's webinar is being recorded, and the recording will be made publicly available a week after the event through the Message website. So to follow along with our presentation on the Message framework, you can now access the full PDF on the messageproject.co.uk website. First, I will hand over to my co-principal investigator of the Message Project, Professor Robin Norton, to say a few words about our work. Thanks, Robin.
Great. Thanks, Kate, and good morning. Good morning, in fact, early morning from Sydney. I'd like to begin by acknowledging the traditional custodians of the land on which I'm joining the webinar today, the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and to extend that respect to any Aboriginal and Torres Strait Islander people joining the webinar today. As Kate mentioned, I've had the pleasure and honour of co-leading the Message project with Kate over the last 2 years. Message has been funded by Wellcome and is hosted by the George Institute for Global Health, based at Imperial College London. Message is a vital component of the George Institute's global commitment to addressing health inequities, and especially its commitment to improving sex and gender equity across the life course. Importantly, though, as many of you know, the Message project and the framework that will be presented today has been co-designed by many project stakeholders committed to finding innovative approaches to improving health outcomes and reducing health inequities for all people in the UK and globally. As Kate said, we're thrilled to have a fantastic group of speakers and a fantastic group of attendees joining us today. We look forward to hearing from our speakers and indeed engaging with them later in the session. So on behalf of the Message team and the George Institute for Global Health, welcome, and we hope you enjoy today's seminar. Thanks, Kate, back to you.
Thanks, Robin. And now I'd like to welcome our first speaker, Dr. Kat Bohannon. Dr. Bohannon is the prize-winning author of Eve, How the Female Body Drove 200 Million Years of Human Evolution. Her writing on sex and gender differences has won plaudits and converts with its deep scholarship, powerful storytelling, and energetic wit. Dr. Bohannon is going to set the scene for why considering sex and gender is so important. Over to you, Kat.
Good morning, everyone. Hello. Hello from the United States of America, where it has been a week. Okay, we're just going to leave that right there on the table and start our day. Okay, it's 6 a.m. here in Seattle. So I'm going to take you back to a slightly happier time, a slightly rosier time. Let's go back to 2012. Right. I am a grad student at the Columbia University, and I am a sci-fi fan. So I have gone to see the film Prometheus, which is the prequel to Alien. We're not going to get back too far into it. All you need to really know is that Dr. Elizabeth Shaw is our final girl. She's going to be the head of this film. And she has, because Mr. Ridley Scott, her director, has made decisions, she's been impregnated with a vicious alien squid. So in this scenario, she wants what a very normal thing would be to want, right? She wants a C-section. Right. So her spaceship has landed, and the future of all medicine, as we know, is a kind of med pod. It's a kind of sexy coffin. That's where all medicine is going. Basically, she goes up to the sexy coffin and she says, I want a C-section. And the med pod tells her, beep boop, terribly sorry. This med pod is calibrated for male patients only. Please seek assistance elsewhere. What follows is a gruesome scene with a lot of lasers and writhing tentacles and blood. She basically gives herself a section in a med pod with some lasers and staples, and then more terrible things happen to her later, but she survives. We don't know how or why. The point of what I'm telling you is that when I'm watching this in 2012, it's in a darkened theater in New York, and I hear a woman behind me say, shit, who does that? Exactly. Who does that? Who sends a multi-trillion-dollar expedition into space and forgets to make sure that the medical equipment works on all of the bodies on board? For example, on women. But oh, I was a grad student at Columbia and I happen to know, right, that's actually us. That's you and me and everyone watching this webinar right now, whatever a webinar is, the future of communication, right? It's you and me, and everybody who has ovaries is already in many ways Dr. Elizabeth Shaw, because of course there is such a thing as the male norm. For a very long time in biology and biomedical research, we were effectively only studying male bodies. I'll give you a very quick overview. There is such a thing as a menstrual cycle. In mammals, we call this the estrous cycle, which is to say we have in the female body, most often, a cascade of hormones that is semi-predictable, that happens cyclically, and it happens in different ways in different species, but it happens is the point. And of course, since there are sex hormone receptors in nearly every tissue in mammalian bodies, which we poorly understand because we hadn't been studying them, well, you want to be a good researcher, you want to be a good scientist, you want to control for your confounds. For once, this isn't a story about sexism. There is such a thing as sexism, but in this case, to build an elegant experiment, it was effectively universally decided in the middle of the last century to just not study the females. Let's pretend the body is a Mr. Potato Head. Let's pretend the gonads are hot swappable for a hot minute, which was the model, which was the norm, which was the thinking at the time. And so, well, fine. Meanwhile, because of thalidomide in human clinical trials, it was decided in the United States and elsewhere that maybe we shouldn't include females of reproductive age in clinical trials because we didn't want to screw up the babies. Because maybe we kind of screwed up some babies for a while. I wasn't alive yet, but there were some babies, there were problems. So no females of reproductive age unless you had a really good reason. Of course, when you think about what reproductive age is, let's see, that's about 11, sliding down these days, 50 something. Oh, that's most of our damn lives. Right. So what happened then for decades and decades and decades is in clinical research, we were not studying females anywhere along the research chain, not in basic science, not in applied. And then when you get to human trials, quite often not human either. Now, what were the consequences of this? Oh, just a few. Now, you've probably already heard about the developments in heart attack symptoms and other kinds of things that present differently in female patients. But let me give you something a little bit more basic. For a very long time in the United States, because the FDA did not have rules that required female bodies to be properly studied, that meant a great host of medications arrived on the market having never been studied in female bodies and never having properly studied sex as a biological variable. Opioid drugs are some of the most common and famous cases of these, because in female patients, especially of females of reproductive age, but still true after menopause, female patients need a little bit more of most opioid drugs to achieve the same level of subjective pain relief. You need a little more. And the slope at which it leaves the body tends to also look a little bit different. And it's not a mass problem. You'd think it's how big the body is, right? It's actually a liver problem. How it's metabolizing through the liver turns out to be quite often sex specific, which created a very unique pathway for addiction, right? Because that's precisely a way to become addicted to a prescription drug. You need a little bit more of it than the prescription that's written tells you it does. Maybe you start cutting your pills. Maybe you take it a little more quickly than that 6-hour window, right? And so you begin front loading an amount of medication in the system that precisely makes you vulnerable to addiction. There are so many cases like these. It's not true that every medication is screwing over chicks. Okay, that's not what I'm telling you. It is absolutely the case that we were running blind for a very long time. In the 90s, the FDA in the United States finally said, Right, sorry about that. So maybe we should include females in our clinical trials. We're going to change our rules, and okay, cool. But then in the 2010s, the NIH in the United States realized, well, if you don't actually study females along the research pipeline, then you're not going to actually arrive at clinical trials with a proper distribution of options for people with different sorts of bodies, right? Because of course we are mammals. So if our mammalian models are male, 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 you're not going to arrive at treatment. So they started to change the rules as well. But I can also tell you that change is hard, because what we're talking about in many ways is a paradigm shift, right? Because we're shifting from a mono model, right? A Mr. Potato Head, if you like, to at the very least a dual model. And what we're really trying to do, and this is a big thing in message, we're trying to split it into an incredibly diverse model of multivariate analysis, right? We're going from one thing to many things because the body is made of complex systems. And we are complex systems embedded in social systems in this hypersocial species that we are, right? And so change is hard. Because what does it mean? It means that you need to change regulations. You need to change regulations at places like the FDA. You need to change regulations at places like the NIH. We are an international community of scientists and clinicians, and we know that this is an international effort, but rules country by country tend to vary. And that can mean that you end up citing bodies of literature that are operating by different rules. These are things we need to fix too. It's also true that we need to admit that maybe we were wrong, which is hard. Okay? That is a hard sell. You need to convince people who have had absolutely illustrious careers that they may have had 20 years of research creating poor models. So that's also a challenge, but that doesn't mean it isn't achievable. And I think Message is doing really, really good work here to get us somewhere where the UK can not only match what the United States has been able to do, but improve on it. Because of course, we're not just talking about sex anymore. We're also talking about sex across the lifespan, and we're talking about gender, right? Because it would be really astonishingly stupid to assume that a pregnant adult human female is going to be operating in all of her tissues in the same way as a 12-year-old girl, right? That would absolutely, probably not going to be the case for her heart health, for many of her metabolic measures, for, I don't know, just about anything you might want to ask. So you need to say where in the lifespan. You also want to talk about gender and how culture is influencing gender. Because, for example, in research in Africa, you'll see something like schistosomiasis. So this is when snails do terrible things to you through public water. Some of you know what I'm talking about. Some of you don't know. All you need to know is there's such a thing as parasites, and they're bad. Right. So the thing that you should know here is that there are both sex and gender influences on how likely you are to get infected by the terrible snail. Okay. So sex is what in your immune system might be influencing your inflammatory pathway to make you more or less likely to have a certain egg burden. This is what they call it. Thank God in the UK, not so much. But in a lot of the world, yes, okay? So your egg, which is how infected are you and how much are you carrying this burden of this medical problem? However, gender in a place like Sudan, where you're washing the laundry in the local canal and you are female and you have expected gender roles, gender in a place like Tanzania, where you're carrying the infected water on your head back to the village, is what's shaping how likely you are to be exposed to the infected water, right? So if you don't actually separate both out in a global health analysis, you're not really seeing why it is one population is carrying more snail eggs in their body than another, and how they're responding to that infection. And that's going to be true of many, many different types of analysis. So you have to be able to analyze both. I suspect in this webinar, you're going to dig into what we really mean by sex and gender differences, and how actually it's a pretty complex array of things that one could look at in one's research. But the real takeaway here isn't simply that we want to reduce the burden. We know that women and girls of all types and non-binary people have been understudied and undercared for. We know that that is the case, but it's not simply a matter of pity that we do what we must do to change our research design, to change our rules, right? Because pity is brittle, okay? Pity is time bound and it easily collapses. It's actually the case that what you get here is payoff. What you get here is actually improved scientific models that better represent the bodies that you're trying to study. What you get here actually is an enormous potential for future treatments that are better individualized. And weirdly, what you also get here is better research to support medical treatment for male bodies. Because actually, if we don't know why it is that male bodies tend to die sooner than female bodies across many mammalian species, including our own, some of which is gender, some of which is sex, then we're actually not treating male old age very well at all. The future of gerontology is absolutely digging into what sex differences there are and why they matter. So I would lean hard on the payoff because there are going to be ever so many. Thank you.
What a fantastic introduction to sex and gender and why this matters so much. Thank you, Kat. Now to introduce our second speaker today, Susan Cole is a health equity change maker, writer and advocate. We are indebted to her for sharing with us how gaps in research have affected her experience as a woman living with HIV, as well as the evidence she's heard from affected women in her network and community. Thank you, Susan.
Hello, thank you all so much for having me. It's wonderful to actually be following an analogy of an alien for once in a scientific presentation. So thanks for that, Kat. As a woman living with HIV, research has been incredibly important to me from the time of my diagnosis. I was diagnosed through a routine immigration test with HIV 25 years ago. I knew very little about HIV beyond the tombstones and iceberg campaigns that we had in the UK. And I received my diagnosis being told by the immigration doctor, well, the good news is you don't have syphilis, but the bad news is you're HIV positive. Oh, and you have about 7 years to live. My children were only 4 and 6 at the time, so you can imagine how devastating that was for me. But I actually managed to cope with my diagnosis through turning to research and finding out that there was effective treatment, that the doctor was wrong, and that women like me can live normal life expectancies and have children born free of HIV. Despite the tremendous progress that we've seen in HIV and HIV research, women with HIV continue to be underrepresented in clinical trials, despite the fact that 52% of people living with HIV around the world are women. I consulted with women living with HIV for this talk today, particularly members of the 4M network of mentor mothers, and they raised a number of concerns to me. One of them is the fact that there just is not enough data on the efficacy and side effects of treatment that we're taking. This impacted me when I was pregnant with my third child. I was living with HIV. I was taking my treatment 100%. But then my viral load started to rise. And initially I was told it was because I probably wasn't taking my treatment properly, but that wasn't actually the case. It was the fact that there wasn't enough research about drug levels during pregnancy. And similarly, I've had issues like that when I was having chemotherapy for breast cancer. Another issue that comes up a great deal with women is side effects, particularly around weight gain for women with HIV. Many women I speak to talk about side effect being a real issue, but often when we go to our doctors, we're not believed and our concerns are dismissed. This was the effect that this had on one woman that I spoke to, who actually cut down on her levels of HIV treatment as a means of trying to deal with the side effects of weight gain, because she felt that no one was listening to her and no one was believing her. And you can imagine the impact that that had. For many of us living with HIV, we're growing older, and that's something that we didn't expect to do. So menopause is a real problem for many of us. However, again, there's inadequate research about menopause in women with HIV. We're told that we may experience menopause a little bit earlier, and we may experience worse side effects. But the research that that's coming from is often based on quite older levels of research, where women who were involved in the trials actually had other health issues that led to earlier menopause. And again, it's about the side effects of menopause. We're just not given enough information. And as we get older, we have other health issues, and also we see inflammation levels rising. But for many of us, when we go to our doctors to ask about HRT, we're told incorrectly that it's not appropriate for women with HIV. And we get ping-ponged around between healthcare professionals. Now, there are some excellent pieces of research on the menopause, particularly the PRIME study by Dr. Shima Tariq in UCL, that very much involved women with HIV throughout the research process. However, we are not a monolith. Women with HIV, particularly from racially minoritized communities, face intersecting barriers to treatment and staying engaged in care. And we are affected by things like structural racism in the healthcare that we receive. A very important piece of research from the PRIME study was by Dr. Rageshri Dharawan, that found that older women going through the menopause from Black communities were more likely to experience emotional distress, but less likely to be offered talking therapy. And that's something that we see across the board. We cannot consider women with HIV without thinking about intersectionality and the different communities that are affected. Often we're told that we're hard to reach, but actually it's not us that's hard to reach. It's the researchers who are just not doing a good enough job in actually reaching us and addressing the barriers that we face in relation to being involved with research. The women that I speak to are very keen to be involved in research, but we want that research to be meaningful, not for us just to be brought in at the end as an afterthought. Women with HIV need to be involved at every aspect of the research process, from design, delivery, evaluation, actually as researchers. And also, it's really important to actually pay us for our time and respect us. Co-production is crucially important in research projects. And even if people don't want to involve us because they think it's the right thing to do, we need to also consider that it actually makes economic sense to involve women with HIV in research within the research process, because without us, the research is inadequate. And so please involve women with HIV in meaningful research across the board. Thank you very much.
Thank you so much, Susan. Certainly none of those considerations were taught to me at medical school about HIV and its treatment. So it's always excellent to become more aware, I think. And as you say, PPI is such an important pathway to hearing testimony from patients and people with lived experience. And I should say that the perspectives of people who are disadvantaged by sex and gender data gaps has been such an important part of Message. So we thank you, Susan, as well as the patients who attended our labs and spoke with such expertise and conviction around the topics that were under discussion. Excellent. So we'll now share how the message team has been working to address these sex and gender data gaps outlined by Kat and Susan. As we've said, I've been co-leading this project with Robin Norton, and Alice Witt, as our Research and Policy Fellow, has been steering the development of the message policy framework, as well as growing engagement from our stakeholders and with the public. We'll share here why Message has focused its efforts on producing a sex and gender policy framework rather than other possible interventions, and then the process by which the framework was co-designed with our stakeholders. And Alice will then talk us through the new expectations that the message framework details and how we intend the framework to be used. Alice, are we okay with the slides? Perfect. Thank you so much. So definitions have been central to our work, as Kat touched on, and as you can imagine, and I think it's important for us to pause here together just to reflect on what we mean by sex and gender. So by sex, I'm referring to biological attributes of animals and humans, such as chromosomes, anatomy, and endogenous hormones. And by gender, I'm referring to the roles, the behaviors, the identities that people have in society. So to simplify things for cell and animal research, we're interested in the sex of study subjects. And in clinical research with human participants, both sex and gender are relevant. As has been mentioned already, Message is an emphatically inclusive project, and we support inclusion of non-binary, intersex, and trans people in research. As Susan touched on, another crucial consideration is intersectionality, which from the perspective of this project is research that meaningfully accounts for how sex and gender interact with race and ethnicity, with age and disability. We see Message as a building block towards high-quality intersectional research. We're collaborating with partners to share our methods and learnings with researchers who are experts in other protected characteristics, and then to foster further intersectional working. So while Message has been underway in the last 2 years, there has been a growing policy environment that's been supportive of the change that we're seeking. In 2022, the Women's Health Strategy for England stated that a key aim of theirs was to disaggregate research findings by sex and ensure greater inclusion of women in research, which was also noted in Scotland's Women's Health Plan a year earlier. Then the NHS's hopes to further personalise medicine will require better data about the influence of sex and gender on health and disease. Last month, NHS Confederation released this excellent report, which highlighted how some conditions affect females and males differently and disproportionately, while pointing out that there are countless conditions where sex differences aren't known because the research has not yet been done. There is a growing awareness that inclusion is important for research value for money, to advance scientific rigor, and to achieve better health outcomes for all. And as Kat mentioned, it's not just about women and girls, it's also about men, the trans community, non-binary, and intersex people. So having said there's a policy appetite for this, the UK is far behind peer countries in terms of sex and gender inclusion. The US recognized this problem over 3 decades ago, which I think is shocking, and I think it's worth just pausing on that. We are 3 decades behind because since 1993, NIH-funded research has been required to include women. The US then introduced its sex as a biological variable policy in 2016, and Canada and the EU also have sex and gender policies in place. You may be wondering, if you have experience in the policy space, if these policies do exist, do they actually work? Well, thanks to Haverfield and Tannenbaum, who published an evaluation of the Canadian Institutes for Health Research's sex and gender policy over its first 10 years, we can see that policies can have a marked positive effect. So applications which integrated sex increased 4-fold, and those which integrated gender increased nearly 3-fold since the policy was introduced. Reassuringly, I find that overall, applications scoring highly for sex and gender integration were more likely to be funded. So meanwhile, our team back in the UK in 2021 did some preliminary research which showed that not one research funder had a sex and gender policy in place for the research that they were funding in the UK. And so we started Message with a focus on funders to profoundly improve the quality of medical research in the UK by increasing sex and gender inclusion. Our central aim has been to co-design a policy framework which then could be used as a template by funders to ensure a consensus of opinion and a more streamlined experience for researchers than if there were many different policies that funders had, which researchers had to adapt to. We wanted anyone applying for research funding to be prompted to say in their application how they're going to account for sex and gender when designing their study, when recruiting participants, collecting data, analysing that data, and then when reporting results. The Message team has been struck by just how engaged our stakeholders are and continue to be, and their dedication to change. Every single stakeholder that started this process with us has remained involved in Message. We have convened over 50 stakeholders across the devolved nations, including funders, researchers, people with lived experience, regulators, and scientific publishers from the UK research sector, and a selection of those you can see on the screen now. How have we done this? Well, the Message process has been fueled by 4 day-long hybrid policy labs, which encourage collaboration through facilitated activities and discussion. The labs took us, the first lab took us from identifying shared priorities, then we workshopped the policy framing and wording over policy lab 2 and 3, and then looked ahead to Message's growth and sustainability beyond 2024. So I'm now going to hand over to Alice to talk us through the framework's key features.
Thank you, Kate. So as Kate mentioned, the Message Policy Framework has been designed as a template for funders to use to adopt their own sex and gender policy. And this is really to formally expect researchers to consider sex and gender dimensions from those very first stages of study design. The framework's rich content can also be used to shape application form questions, as well as researcher and reviewer guidance, and we'll be publishing a toolkit for funders on how to implement the framework effectively. The framework's also been designed to be read and used by researchers to really understand what they need to describe in their application to meet new policy expectations. So the framework breaks down what must be done to account for sex and gender into 4 key components. Firstly, researchers must set out which sex and/or gender characteristic or characteristics will be accounted for. As I'll explain in more detail shortly, researchers should precisely consider if sex, gender, or both might affect their study outcomes and by what mechanisms, and then plan to collect data accordingly. Secondly, researchers must set out their target distribution of participants in terms of sex and/or gender and give a justification for this. They must then describe the strategies they'll use to meet that target distribution. For clinical research, this will be strategies for recruiting and retaining participants, whereas for preclinical research, strategies should focus on procurement, storage, and housing of cells and animals to reflect that target distribution. For studies conducting secondary data analysis, researchers will be expected to give a description of the sex and/or gender distribution in that original dataset that they'll be using. And lastly, researchers must describe if and how they plan to conduct sex and/or gender disaggregated analyses. By sex and/or gender disaggregated analyses, we mean separating data by gender, comparing the groups, and then importantly, making sure to quantify the difference between those groups. If researchers do not plan to conduct these analyses, they must give a strong justification for why in this application. Importantly, this framework is not prescriptive, but it asks researchers to reflect critically on and be able to justify how, in the particular context of their study, they will account for sex and gender across each of these 4 criteria. If the study does not plan to account for sex and gender under one or more of these criteria, researchers will also be expected to provide a strong justification. Understandably, researchers and funders have several questions about how to account for sex and gender in a scientifically rigorous way. And through our co-design process, we've been consulting with a large range of experts to address these concerns. And there is detailed information on our answers to these questions in sections 2 and 3 of the framework, which you'll see I've popped into the chat. Firstly, the question of how should I define sex and gender? The message stakeholder group has dedicated a lot of time to considering how sex and gender should be defined in the policy framework in a way that is both conceptually sound and has maximal operationalizability in the specific context of biomedical health and care research. Section 2 of the framework is dedicated to setting out how we're referring to the term sex and gender. And our approach is really clear to distinguish between sex, which, as has been mentioned, refers to biological characteristics, and gender, which reflects the roles, behaviours, and identity a person assumes in society, and which affects the power, privileges, and constraints that affect them. Going one step further, this framework encourages researchers to think about the terms sex and gender not as single entities, but rather as encompassing a number of different characteristics. Sex characteristics include genes, endogenous hormones, and reproductive organs, while gender can be captured in terms of a person's identity, their gender expression, so how they present themselves to the outside world, their perceived gender, so how their gender is seen by society in general, or perhaps in certain studies, the healthcare system, or their gender modality, so whether they are cisgender or transgender. The framework encourages researchers to reflect on the precise mechanism by which sex and/or gender may be affecting the medical condition or intervention that they're studying, and to select and analyse participants or subjects in a way that reflects this. One question that we're often asked is whether, in the interests of statistical power, it's necessary to double or indeed further increase some sample sizes. The message framework is clear that although it is ideal if study samples are powered to be able to identify statistically significant results for each sex or gender group, this is not obligatory to meet the standards of accounting for sex and gender. Instead, what researchers need to do is to critically consider how sex and gender may have an effect on study outcomes, and importantly, transparently report on these dimensions in publications. Better reporting of disaggregated data will ensure robust meta-analyses can be conducted, which may identify significant sex and/or gender differences in the longer term. And this is explained in section 3C of the framework. Similarly, researchers often ask what proportion of participants or subjects of each sex or gender they need to include in their study. The appropriate distribution by sex or gender will differ by disease area, and in differing circumstances, it may be preferable for the distribution to reflect society at large, the disease population, or a subset of the disease population. The framework really gives agency to researchers to determine what the best distribution might be, as long as this is adequately justified, including drawing on relevant literature wherever possible. And this is explained in the framework in section 3B. Moreover, a 50-50 male-female split may not always be the most appropriate or inclusive approach. The message framework is clear that researchers must make a proactive effort to include participants who are trans, non-binary, or intersex, or who have variations of sex characteristics. Message guidance will give pointers on how to engage these individuals in an inclusive way, and researchers will be expected to consider the strategies they will use to reach underserved groups. Though trans, non-binary, and intersex people make up a relatively small proportion of the population, it is important that we have a robust evidence base for these patient groups. If data are accurately collected, analysed, and reported for these groups, meta-analyses can be used to make high-quality recommendations for clinical care. Next, there is a widespread misconception in the research community that females should be excluded from research because of the way that hormone variations across the menstrual or estrous cycle, and this is something that Kat touched on. The message framework is clear that this is not an acceptable justification for excluding females from research. Not only have studies shown that female hormone variations affect study outcomes no more so than they do in males, but excluding females from the controlled research environment only to expose them to untested risks at scale is unethical and scientifically unsound. Section 3A sets out appropriate and inappropriate justifications for not accounting for sex and gender in more detail. Appropriate justifications might include if a study is focused on a single sex or single gender phenomenon, such as cervical cancer or men's mental health, if the study has been designed to address historic bias or gaps in the evidence base, or in cases where there are very small sample sizes, such as studies on rare diseases. We know that lots of researchers are keen to keep up with scientific best practice, and as you'll see in section 3E, there are lots of things you can do to begin accounting for sex and gender straight away. These include conducting sex and/or gender disaggregated analyses of your existing study data, reporting findings in a way that clarifies sex and gender dimensions, and identifying areas for future research to explore sex and/or gender differences in more depth. When writing up findings, researchers must make sure to report transparently and explicitly on the sex and gender dimensions of the study. We see all too often that the findings of research conducted primarily or exclusively in one sex or gender are presented as relevant to all people. This perpetuates the one-size-fits-all norm and can have harmful knock-on effects when evidence is used to shape clinical practice. In Section 3F of the framework, we've included guidance on how to report sex and gender dimensions in every part of a research paper. This guidance aligns closely with the SAGE guidelines for sex and gender reporting that have been adopted by a number of academic publishers. Some key points to draw your attention to today are, firstly, in the methods section, always outline the number of participants or subjects of each sex and gender that were included in the sample. We encourage you to explain why this distribution was used, and if you were unable to meet your target, include some reflections on why this might have been. Next, we strongly recommend that you publish sex and/or gender disaggregated data in your results section. And if this is not possible, it's really important to publish disaggregated data in supplementary materials as a minimum. This will enable those meta-analyses which can identify significant sex or gender differences. Similarly, it's imperative to report all findings of sex and/or gender disaggregated analyses, including null findings when no sex or gender differences were found. In doing this, researchers must make sure to quantify all sex and/or gender differences and give appropriate measures of uncertainty when you're reporting those. And lastly, you're encouraged to address the sex and gender dimensions of the study and findings in the discussion, but in particular to make sure to include a reflection on what was done well or what could have been done better in the strengths and limitations section. As I mentioned, detailed information on all of these points is included in the message framework.
Thanks so much, Alice. So to support funders implementing the message policy, our team, alongside fellow stakeholders, and there's been a lot of peer support through this process, have advised on application form wording, providing support for reviewers of applications, deciding on the criteria for evaluation of excellence and what's possible, and upskilling research communities. So if you are a funder who's not yet involved and message resonates with your goals and values, we'd really love to hear from you, and our contact details will come up at the end of the webinar. For researchers who are joining us today, we're also preparing educational materials and an online course to support your learning. These will be accessible along with future resources on the Message website. To summarise, we feel very strongly we're now at a significant turning point in ensuring research works for everyone in our society. And this relies on your commitment and enthusiasm to spread the message in your communities and through the example of your work. We'll now hear from message stakeholder organisations who've been involved in the co-design process and are embedding message learnings into their organisations. So first, let me introduce Professor Lucy Chappell, Chief Scientific Advisor to the Department of Health and Social Care in the UK and CEO of the NIHR, one of the country's largest funders of medical health and care research. NIHR has been a dedicated stakeholder throughout the message process, and we're delighted to welcome Professor Chappell to speak for the funder today.
Thank you very much, and thanks for the invitation to join this. I'm Lucy Chappell, Chief Scientific Advisor at DHSC. I'm also Chief Exec, as you've heard, of NIHR, National Institute for Health and Care Research. I'm a Professor of Obstetrics and a Consultant Obstetrician. So I was going to reflect, first of all, on those different roles. I've been a researcher on women's health for a number of years, and particularly in the area of pregnancy hypertension. And so I see at first hand the need for research inclusion on so many fronts, and more than research inclusion, very much more the wider message. But research inclusion, it starts with that, and you've heard about the much wider framework. And I think we've got two challenges sort of illustrated by my specialty, which have been touched on in the talks you've heard already. Women during pregnancy often face additional barriers to research participation, and women, particularly from certain ethnic groups where you get the intersectionality that we heard about earlier, are often additionally underrepresented in research beyond pregnancy, such as my area, which is hypertension. So I really welcome the steps being taken by Message to tackle this and the support of the NIHR. NIHR's long championed research inclusion and has committed to an approach which really enables and encourages our research community to account for sex and gender in research. So we outlined this in our research inclusion strategy, which sort of covered the years 2022 to 2027, and then we published further as a statement of intent in December 2023, and we're very happy to share those, or you can find them on our website. And NIHR's aim to take an evidence-based approach, really saying what is the need for this work. And you've heard that from some of the speakers this morning, this afternoon. I think I'm not sure which time zone I'm in right now, about women receiving poorer healthcare than men. And we saw that brought out very powerfully from the Women's Health Strategy published by DHSC. I think I found some of those findings quite stark. And I think it's sort of really certainly caught the attention of ministers in the department. But there's also something about women spending significantly longer living with poor health than men, and really thinking about how they access the health services that they need. I mean, an example is that I think a number of us are familiar with is where they're more likely to be misdiagnosed following presentation with signs or symptoms of a heart attack. And it really brings home that if we define things through the male by default model, then we're going to miss so much that's important to help the 51%, as our previous CMO alluded to. So you heard that the NIHR has been involved with the Message project since its inception, and Esther Makuka has been, who's in our team, has been serving on its advisory board. And the Message project's really sort of championed this sector-wide approach. We need everyone to come with us, looking at sort of the best practices, coordinated strategies, doing it similarly across many funders, which we know is important. And I think that initiative really helps that we're not all trying to do it differently, which is what I had seen previously. So NIHR is currently in the middle of change to ensure that the design of research inclusion is properly funded and executed. So we have recently announced that research inclusion will be a condition of funding. As we will then take that on to NIHR launching its first sex and gender and research policy in 2025. So from what you heard in my initial words, you can see that I think it's essential that health and social care research participants reflect the population who need the research most. And so we need to do that to narrow the health inequalities, not widen the health inequalities. And actually, research can be a tool to tackle health inequalities if we design it well. I often talk about research inclusion having there are three benefits. And if you think about the audiences we are trying to reach, we need to ensure that we talk about all three. So I'm clear that it improves health outcomes, particularly through that modality of addressing health inequalities. And that's how we make the biggest strides forward where the biggest gaps are. The second point is that we get a better scientific understanding of what those differences are and what they mean. So I look back on my research, and the difference in response within a research population is often what drives my next research question. So saying that it's sort of too difficult or too messy to have men and women, or saying that can't interpret the results, I just don't really hold on to that from a science point of view. I think that representative population is for the scientifically curious. And then the third one is it makes economic sense, and particularly around adoption of research into policy, practice, and guidelines. Why would you design an intervention for only half of your population, or for an even smaller subset if you look at the intersection between sex and gender and ethnicity as well. And I also think that the fourth sort of driver of this is quite rightly that the health and care regulators are taking this forward through better inclusion of representative populations in research. And our UK Health Research Authority and the MHRA are in the middle of updating their guidance on this area. So I really see it that by looking at our policy and practice around sex and gender, we really want to boost health and care outcomes for women and the whole population. So I've touched on the fact that this supports our women's health strategy, and we committed in that research that does not take into account sex and gender-based differences does not receive public funding. But I'd like to enact this by bringing our communities to look at the positive opportunities that come with research inclusion. And this really talks to one of our central themes in NIHR, which is impact. So it's not enough just to write it into the grant application. We will be monitoring to look at how we drive that. So for many years in clinical trials, the first time you see your baseline characteristics has been at the end of the trial when you look at your table 1. And frankly, that's too late. So really what we want to ask of our investigators is you would want to know what those baseline characteristics are. And so I'm heartened by many researchers now looking at their baseline characteristics as the study progresses, not waiting till the end. So we need to have a sort of iterative approach to this. And similarly, we need a continuous learning approach to all of this work, learning as we go. So I'm going to finish by saying, in my clinical practice, I have seen at first hand what a difference this approach makes to the care we provide and the improved outcomes. I've been doing those clinical trials for pregnant women for many years, and if we offer informed, ethical options, pregnant women make choices and they take part with alacrity because they understand the gaps in their knowledge. And in the COVID pandemic, as the National Pregnancy Lead for the Recovery Trial, I saw the systemic barriers both from the system, from the workforce, to ensuring that pregnant women could take part in the recovery trial to access potential treatments for COVID. Because otherwise you're saying they're just going to have to make it up after the trial's been completed, and they're left at the back of the queue. So I think we can change this, and through the Message Project, I think it's extremely opportune that we've come together, particularly across the communities, to drive this. And I look forward to further work on this. Thank you.
Thank you so much, Professor Chappell. The breadth of your experience and expertise, as you outlined, is just so helpful in capturing why research inclusion should matter to everyone, from clinicians, funders, researchers, and ultimately patients. And thank you so much for your leadership in this space. Now to our next speaker, Dr. Diego Baptista. Dr. Baptista is Head of Research and Funding Equity in the EDI team at Wellcome. As Robin mentioned, Robin's Message has been funded by Wellcome and has also benefited from Wellcome staff's insights as stakeholders in our policy labs. I'll now hand over to Dr. Baptista to talk more about Wellcome's hopes when Message received this funding and Wellcome's ongoing commitment to sex and gender equity.
Amazing. Thanks so much for the introduction, Kate. Hi, everybody. I'm actually not sure I'm going to add too much value because most of the content that I was thinking about talking about we've heard, but I'll try to reiterate some things and talk about how it's important to Wellcome. So I'm super thrilled here to be able to discuss why Wellcome initially decided to fund the co-design of this new sex and gender policy framework through the Message Project. This initiative, as you've heard, is crucial in ensuring that research considers the various and diverse sex and gender perspectives, which we think will lead to more equitable and effective science, and that's really important to us. I'll talk about the 3 core motivations for funding this. Wellcome's history of shaping research policy in the UK and whether or not that's a positive or a negative, I'll let you decide. They identified gaps in sex and gender analysis in the UK, which we've heard a little bit about, and how gender equity aligns really strongly with Wellcome's mission. So Wellcome does indeed have a rich history of developing policies that influence research practices, and a lot of this work, you would say, is influencing behavior change in researchers. So our role extends beyond just the funding policies to include collaborations with key stakeholders, which the Message Project has done really, really well. So other funders, regulatory bodies, researchers, UK higher education institutes, those with lived experience, etc. As an example, our work on open access policies set really high standards for transparency in research dissemination. We were really delighted to see a project that was focused on thinking about sex and gender considerations in research as a policy framework to influence the UK policy ecosystem and globally if possible. A great paper from colleagues, I don't know if you know Dr. Lillian Hunt, looked at sex, gender, and diversity analysis and research and identified that there's a gap within the UK research ecosystem in this area, which we've already heard about. As a research funder with a significant funding footprint in the UK, Wellcome wanted to support the progress of science and advance health research in an equitable way, and this very much includes gender equity. So this brings us to the reason why Wellcome saw an opportunity to think about sex and gender research in the first place. As you've heard, there's significant gaps in health research knowledge with respect to sex and gender. For example, the historical exclusion of women and pregnant people in clinical trials. Many drugs and treatments lack specific safety data that's gender inclusive or relevant. This has created substantial evidence gaps, leading to uncertainty in clinical care and treatment decisions. And what we know is this is a really challenging issue to solve, is there's many different pieces of the health research puzzle that our colleagues have done really good thinking about, and these pieces need to fit together to solve this. We're certain that getting researchers and those who make research happen to improve their considerations of sex and gender in their own research or the way they support research is a route to this. And I really like the good balance of prescription that you see in the framework itself, because we don't know a particularly good way of doing this. And so how do you stimulate innovation in a way where you can actually build evidence that might be able to be disseminated more widely? It's really, really good to see. The last thing I'll touch on is in this part is how integrating sex and gender analysis, as we've heard, into the design of research where relevant can make research more excellent, if we want to use that terminology. So it improves the research methodology, makes the research more responsive to social needs, makes the research more impactful across big populations. Wellcome's mission to solve the urgent health challenges facing everyone, and this includes folks from all the wonderful flavors of gender, including those who reject the social construct of gender, is important. Diversity efforts in research, including those embodied by Wellcome, have long thought about the quantitative numbers of who gets to participate in research. And while this is an important aspect of equity, diversity, and inclusion work, we need to move beyond just the numbers of who gets to participate and perform research and start thinking really critically about the content of the research and how that content intersects with people's identities, and how thinking about that intersection will make it so that the outputs of that research can apply to broader populations. I've spoken a little bit about how sex and gender can inform each phase of the research process, from establishing project objectives to developing the methodologies, gathering and analyzing the data, and reporting the results. Having clear guidelines and generating evidence for these different approaches when you're considering sex and gender in the research process will help our aims at developing and supporting research that's equitable in its impacts. What we want at Wellcome is for our funded research to be as impactful as possible across all the populations that can benefit from research. This also means how we support research to understand avoidable differences in health and to develop the solutions to address these, or at least convince those people who could address these to do so. A coherent approach to sex and gender considerations in research across the UK will be really helpful in this aim. And essentially, it'll help make the benefits of research mean more to more people. I'll end with how I think sex and gender intentional research is a kind of wedge into thinking about our longer term ambitions to realize intersectional research and enhance the intersections of all of the wonderful identities that people have and research that should be conducted. So as you'll all be well aware, there's many aspects to identity as we conceive it that will have an impact on how research is done and what research question is asked. In the end, how that research question can be beneficial for populations. It's really important for us to move towards how these identities are important when you're developing, designing, performing, and disseminating research. There's a variety of approaches you could take to move towards tackling this incredibly complex system. Sex and gender intentional research is not an endpoint, as we've heard, but a stepping stone towards broader ambitions for intersectional research. I view it as, you could try to get everything right with every identity dimension and release a policy framework. Or you could think about using a particular identity characteristic to set a wedge in, and essentially you're trying to get people's behaviors to change as they're designing research. And once they've gotten an idea of how to consider sex and gender or an identity characteristic within their research, they may be more open to other identities as we learn more about how to consider them within people's research. Identity is multifaceted. Aspects like race, socioeconomic status, and cultural background interplay with sex and gender, which will influence research needs and impacts. But I think we need a little bit more time to understand how those interplay with one another, and get people to be excited about understanding them. So as you've heard, the Message Project aims to integrate sex and gender as a fundamental consideration in health research. Wellcome's super supportive of this. This aligns seamlessly with our vision of a future where health research is fully utilized to solve urgent health challenges. In addition, we want research to be inclusive, impactful, and responsive to societal needs. So by supporting Message, Wellcome is helping to forge a path towards a research culture that readily embraces diversity, leads with integrity, and delivers benefits equitably. Thank you.
Thanks so much, Diego. I really like what you said about behavior change towards greater inclusion and just how hard that is. That also resonates with what Kat said earlier. And that image of the wedge coming in and trying to get people's resistance prized open a bit so that they can embrace more intersectional work. This project just really wouldn't have been possible without Wellcome's support and Wellcome's belief in our outlook and methodology. So thank you. And you also mentioned Lillian Hunt. Their support through EDIS has been also crucially important in Message's progress. So it would be remiss of me not to emphasize that here. So to complete our tour of key parts of the research pipeline, we welcome Dr. Richard Horton, Editor-in-Chief of The Lancet, one of the world's most influential and scientifically rigorous medical journals. The Lancet and its publisher Elsevier have been key stakeholders in Message and have contributed their insights into sector change and the necessary levers needed to improve research quality and inclusion. Welcome, Dr. Horton.
Thanks very much, Kate. It's great to be with everybody. Really appreciate you inviting me. First, let me thank my colleagues who've really made the significant contributions to this project. Lan Smith, Editor-in-Chief at Lancet Haematology, Agnieszka Freda from Elsevier, Isabel Goldman, who was at Cell Press, Heather Van Epps, who used to work at the Lancet, is now at PLOS, and Emma Rourke at the BMJ. It's really their work that has helped get us here today from the publishing editing side. Let me just put on record that I so much welcome these recommendations, which have come from the kind of collaboration that I've never seen before in 25, 30 years of working in UK medical research. A collaboration between editors, publishers, researchers, clinicians, patient representatives, regulators, funders. It just doesn't happen, and it should happen more often. So massive congratulations. There are several really important implications for scientific publishing that come out of the Message project, and I want to just focus on three of those. The first and really obvious one that several people have mentioned already, and it seems so obvious that one shouldn't even have to mention it, but it's so important to underline, and that is the correct use of the terms sex and gender, because we see time and time and time again the enormous confusion that there is about the use of these two words. And it's not only confusion, there's also this, and it's completely understandable, nervousness about the use and meaning of the word gender in particular. People are scared of using the word gender because it's become such a politicized and often abused and attacked word. Just open the pages of the Daily Mail on any random day and you will see how that newspaper and how a very big part of our mainstream media is lining up against trying to undermine the concept of gender and gender identity. But from our side, in the health and medical science community, it's really, really important, and this is what Message does so well, it's really important that we assert the importance of taking gender into account when we consider any dimension of health. Let me just say that next year we're going to be publishing a really important, I think really important Lancet Commission on gender and health. And that commission, that's led by Sarah Hawkes at University College London, aims to show the absolute central importance of gender justice if we're going to achieve global health equity. We can't achieve global health equity unless we put gender justice absolutely front and center of our objectives. So bottom line on this first implication, we all need to take gender and the meaning and implications of gender a lot more seriously than we do today. Second implication, the message recommendations are going to encourage, and this again has been mentioned, a consideration of how sex and gender might be relevant to a study's outcomes. So important. So message is a manifesto. It's a manifesto for editors and it's a manifesto for publishers. It's a manifesto for editors for us to think about sex and gender when we're reviewing a manuscript, to encourage authors to report the sex and gender distributions of their study participants, to consider conducting the appropriate sex and gender and analyses, and if nothing else, to absolutely discuss dimensions of sex and gender in the discussion section of a paper. But it's also a manifesto for publishers, because you publishers have to hold your editors, people like me, accountable for taking sex and gender more seriously. Publishers can ask their editors how they're going to respond to, how they're going to implement the message recommendations. And the third implication is that these message policy guidelines are a part of what we in medicine and science should be pursuing as a larger goal, and that is to continually expand the circumference of equity in health, because medicine has to face up to the incontrovertible and terrible historical fact that gender inequity is hardwired into the health and health research system. Even today, it's hardwired into the system. Let me just give you one example: women and cardiovascular disease. We investigated a few years ago some of the deep gender disparities in research on heart disease through a Lancet Commission on Women and Cardiovascular Disease. It was chaired by the fantastic Roxana Mehran, who's a professor at Mount Sinai in New York, and we published that commission in 2021. Remember, it's often forgotten that heart disease accounts for 1/3 of all deaths in women. You wouldn't believe it if you looked at the attention that heart disease is given, both in the media and in medicine generally. It's hugely neglected in research at a time, amazingly, when ischemic heart disease in young women is on the increase. So we should be paying more attention to heart disease in women, and we're not. Because the truth is that the majority of the evidence available about the treatment of any heart disease, any cardiovascular disorder, comes almost exclusively from randomized trials, including only, you guessed it, men. This is mad. This is a crazy state of affairs, not least because cardiovascular disease is often completely different pathologically in women compared with men. So to assume that the result of a treatment trial in men can be immediately translated to women is just fundamentally mistaken. It's a serious category error. So now what we're seeing is that the entire knowledge base of cardiology is having to be slowly rewritten. Studies are now underway that are looking very specifically at the unique dimensions of women with heart disease. Give you just a couple of examples. The Warriors trial, based at Imperial College London, is assessing whether women with abdominal aortic aneurysm are being treated too late. The Recharge trials, comparing 2 procedures to restore blood flow to the heart. These are basic questions that we have not answered. I mean, it's impossible to fathom that we're now having to go to such fundamental, madly, stupidly basic issues in medicine, and we're having to start building the knowledge base right from scratch. And we're doing this because women have been systematically excluded. And the goal here is literally to reboot the entire research ecosystem to achieve gender equity. It's a massive exercise and we're only just beginning. And I think that what the message best practices are going to do, they're going to accelerate this rebooting of the research ecosystem. They're going to accelerate the rewriting of the knowledge base of medicine. There are some challenges that we need to acknowledge. We can't do as editors and publishers this alone. This has to be a system-wide change. All of us have to jump together. So I hope we do. Second, there's one group I haven't mentioned, and that's peer reviewers. And we need to embark upon a massive awareness building campaign amongst our peer reviewers who may not be familiar with some of the principles around sex and gender. Third, we editors have to consistently apply these recommendations in our decision making. And this week at our Thursday manuscript meeting, I'll be sure to be setting out the key guidance in the message best practices. Fourth, we've got to get all journals and all publishers to adopt these guidelines. One route is through the International Committee of Medical Journal Editors, and we'll certainly be tabling message best practices on the next agenda. And lastly, we need to find a way to monitor our progress. We're all making big commitments today. That's fantastic. But we need to monitor the progress, we need to review that progress, and we need to make sure we're living up to our promises and our commitments, and then course correct if we identify any deficiencies and gaps. So let me finish and reiterate, at the Lancets, we're super excited by the opportunity that the Message Project presents. Thank you. We will do everything we can to see its vision is fully realized. Amazing work.
Wow, thank you, Richard. What a commitment. That's wonderful to hear. I'm going to pick up on something you said right at the beginning, which is you're absolutely right about the nervousness, I think, in this space, about getting terms wrong, about getting ideas wrong. And on reflection about the message process, I think the Policy Lab space was just so helpful in letting people take uncertain steps, in trying out ideas, in learning from each other. And the fundamental sort of opener was that we all make mistakes. And we very much hope that the message framework will change, it will improve, it will evolve as thinking and research evolves. So we're just at the beginning, as we say.
Fantastic.
So thank you. That concludes our panel of speakers, and we now turn to our Q&A feed, which has been filling up over the last 75 minutes. Thank you to everyone who submitted questions in advance and during the webinar, and really just for your engagement with today's presentations. It's been fantastic. So I'll hand over to Alice, who I think has been grouping your questions in an effort to maximise coverage on the topics you care most about. So Alice, do you want to take over?
Yeah, absolutely. And thank you again to all the fantastic speakers today, as well as to the audience who, as Kate says, have been filtering in these great questions through today and ahead of the event. I think just before we dive in, I'll just address a couple of the more factual questions that have come through. So there's one question asking, is this applicable to all medical research or just clinical research? So just to really underline, the message policy framework is addressing all medical research, as in the kind of as broader terms as that can encapsulate, so that we're thinking preclinical research, so your cell and your animal studies, through to kind of clinical trials and other medical research involving human participants, and all the way up to kind of population health, kind of epidemiological studies. So really a broad scope. There's also been a question asking, have there been any men's health organisations involved in designing message framework? The answer is absolutely yes. We've had representatives from the Men's Health Forum, as well as men's health researchers involved in their kind of researcher capacity. And lastly, a question I don't have the answer to is there an equivalent organisation to Message tackling sex and gender in research across non-medical disciplines? I don't know if anyone on the call has an answer to that. I'm not aware of any, but if there are, we'd love to meet them to share knowledge and think about kind of ways forward. Okay, go ahead, yeah.
I think we should just mention our TGI colleague Kent Booth and Sarah Hawkes, who have been doing work through Global Health 50/50, and I think they're starting to look at legal spheres, engineering. I know that they have a really broad reach, so do look out for their work as well.
Brilliant, thank you. So we'll move into some of the questions I've been grouping together. So a first question for you, Kate. How will we measure the impact of new policies?
Such a great question, and a question that we've been thinking about from the off. And luckily, we have some precedents for how to measure impact. So I guess I would first say that the impact is already happening, that message is spreading through events like this, and also through our stakeholders who are sharing the work they've been doing through the project. One metric for us that's important is how many funders go on to implement messages recommendations. And as Richard said, sort of not just while it's flavour of the month, but actually follow through with these recommendations so that they become normalised, so they become, I guess, boring over time. And everyone just thinks, well, of course, that's how you do good research. I mentioned earlier about Haverfield and Tannenbaum's paper, and as a group, as well as with our stakeholder group, and I should say that they are part of the message writing group, so we've involved all of our stakeholders as co-authors. We hope to use that paper as a model and compare baseline data about how many applications are currently integrating sex and gender, and then compare that to what we see in 5 years' time or so. So I guess the other thing about that is it's going to be a big piece of work. So it's not just a single funder. It's not like looking at NIH or CHR. It's going to be across the sector. So everyone's holding their breath a bit about how we'll do that. But I think it would be really important to show the impact. And then sort of as a clinician, I'm always aware of the really important things that are harder to measure. So really, the thing that matters most is how this might filter through into clinical practice and then go on to improve patient outcomes, which is hard to measure. So you kind of have to look at surrogate markers. And one thing we've been looking at is NICE guidelines, which, as many of you know, are guidelines for best clinical practice in all kinds of disease areas and specialties. And we've been looking at those guidelines to say, do they think about sex and gender? Is that part of the recommendations, and not just if you're pregnant, don't do anything, but really sort of thinking more holistically about difference and inclusion. So we've done that baseline review, and I think it would be fantastic to come back to that review. Maybe it would take a bit longer for the research to trickle into clinical practice, but maybe in 10 years' time, and to say, oh yeah, okay, so clinical practice is moving forward as well. That for me would be, I think, a real confirmation that this work has taken on. And obviously I want to pay tribute to all the other projects that are working on inclusion and furthering sex and gender, and so message is just part of that effort. But yes, seeing that in 10 years' time would be fantastic in terms of impact.
Brilliant, thank you. I wonder if there's anyone else on the call who wanted to add anything more to that question of how do we measure impact and what does impact look like? Yes, Robin, go ahead.
I think the other thing that we're doing, and Kate and Alice, you might want to comment on that, is how do we engage with the business community, and thinking about product development, whether it's pharmaceuticals or medical devices. So we really want to look across that whole spectrum, and that's certainly part of the engagement that Kate, Alice, I know that you're starting to consider as well. Thank you.
I'll just come back in on that, Robin, about industry, yes, and also the pharmaceutical industry. We've been partnering with Women in Pharma, who are doing extraordinary work raising awareness amongst their colleagues. So I think research, and particularly sort of government-funded research, is one thing, but there is this whole other question about the pharmaceutical industry and how we engage them and why this is important.
Richard.
Thanks. Yes. I mean, if we think about message as part of this wider movement for gender justice, then we should also be thinking about a broader basket of metrics for progress. Let me just give you a couple of examples. We did a piece of work, we published a piece of work a year or so ago on women, power and cancer. And what that particular project found was that amongst a bunch of oncology journals, very few women were editors-in-chief. Now, this is the power structure of medicine that we're trying to address. And so measuring the number of editors-in-chief of journals is a very easy thing to do. And that's one metric to see whether we're approaching gender justice. Also, the professoriate. Are women making it through to the glass ceiling? And not just professoriate, but then at the highest levels, provosts and vice chancellors of universities, how many women do we have? So I think there are ways that we can identify progress. Elsevier, our publishers, published a report on gender last year. And that one argument there was, although we're seeing more women included in the authorship byline of papers, which is a good measure of some progress, there are still huge barriers for women in science that we can measure, we can track. So I would encourage us to think about message in the sort of broader movement towards gender justice.
Thank you. Diego.
Yeah, I think it'd be interesting to look at once funders, for example, have put policies in place. How has that changed how applications are coming in for funding and spoken about? And then eventually, how is the research that's being done producing evidence that says, okay, if you're working with these particular cell types or brain disorders in mice, this is how you might want to parse out the sex of mice, for example, as you're doing research. And so as we've released this policy, how do we see research evolve through the kind of upstream from people aspects of it, which hopefully eventually will have those downstream effects that we want to see?
That's fantastic. Thank you, everybody. And I think that's exactly right. It's that kind of back and forth and sharing of information. As Kate mentioned, we're all on a learning journey here. And it's about not being kind of punitive and critical, but actually helping each other to understand more and providing that feedback and generating that learning. I think one of the key things we've got in that in the framework is the guidance kind of on reporting. If things haven't gone well in terms of sex and gender, please talk about this. Please give some suggestions of why that might be, so that we can understand what's working and what's not, and actually how we might address those gaps. That's brilliant. Okay, so I'm just looking at all of the questions that are coming in, and I'm conscious of the time. I wonder if a next question might be, how do we think about how the message model can be adapted in other contexts globally? So I think within message, we have this excellent methodology that we have found, as we've talked about, so engaging, and that has brought together so many perspectives. And then there's also the actual guidance that we've got. I wonder if there are some people on the call, given that we are a relatively international group, who might want to share some perspectives on that kind of longer term vision. And I think that does come in, it does feed into the conversation about how do we involve industry and biopharma in this question when they're operating at that more international level. Wonder, Robin, if you might like to start as an answer to that question.
Absolutely, and perhaps use the example of what colleagues at the George Institute have been doing in Australia. And so earlier this year, we launched a National Centre for Sex and Gender Equity in Health and Medicine. We've worked with the major funders in Australia, the National Health and Medical Research Council and the Medical Research Future Fund. As Kate and Alice know, very parallel programs of work that we've been engaged with. Working with the Australian Association of Medical Research Institutes to develop policy. So a lot happening in Australia, and I think, Kate, Alice, you're aware that we want to engage with our colleagues across the world, particularly in the George has offices in India, where we're hoping to work with our colleagues there and look at working with similar sorts of stakeholders to that which Message has been doing.
Is there anyone else who'd like to come back on that question? Kat, go ahead.
Hey, yeah. So in the US, we're occasionally in this space held up as the success story in the 90s with the FDA and, and then the NIH and what have you. I can tell you that one of the things that we're really working on is we need both the push and the pull scenarios. So the push, you might say, is the punishment scenario, which is the rules of the NIH, the rules of the FDA. What happens if you don't comply, right? We're actually working pretty hard on the pull scenario, which is to say partnering with private, partnering with pharma, partnering with medical device research, partnering with spaces that make it more rewarding to do this research, right? So for example, We know in pharma spaces, I've had many conversations, that there are so many discarded clinical trials in phase 1, right? So many, where it is also true that females are radically under-enrolled. It just continues to be a thing. We have the rule, but we have a problem with enrollment, which is a complex problem, right? But I can tell you that many stakeholders in pharma would love to have many of these candidates for treatment be returned to see if they could prove useful in female patients, right? So that's one of the opportunities we're working on. Like, okay, pharma, if you invest in this, maybe you can actually get back some of that investment you've done previously and not consider this the waste bin of phase 1 trials. So that's one of the things that is starting to really take shape in the US. And I think that that's going to be true in international spaces for private medical research as well.
Thanks, Kat. Richard, did you want to add something?
Well, I was just going to say that perhaps we should try and get Diego's old boss, Jeremy Farrar, who's now head of science at WHO, involved, because there's no question that if you get the World Health Organization behind something with its tremendous networks, then we might be able to, really create a real global wave with message. So I think I would drop Jeremy a note and send him this and say, come on, what's your response? Get involved.
Brilliant. Thank you, everybody. So I'm mindful of the time. I think I'll just wrap up with one last question. And it's kind of a question for everybody, but perhaps we'll start with Susan. And the question is, what's the first thing that I can do, what I should do to start considering sex and gender? There's a lot of enthusiasm coming through from the chat, people saying, I want to get going. So what would be your top tip for getting started?
And I would certainly say one of the most important things is to also consider intersectionality within your approach, because it's not sufficient to just look at sex and gender, but actually recognizing that there's a need for action is the most important first step.
Who'd like to jump in? Anyone else? Diego, I'm going to put the spotlight on you.
I was trying to figure out how to raise my hand because I'm on the browser. I'm going to say the really obvious, easy answer, which is engage with the framework that's being released today. There's lots of stuff that's interesting for funders, but also every participant and player in making research happen that will be useful to understand and then try to build into your practice as you're doing the activities that you do.
Thank you. Kate.
I think being aware is so key. And when we're consumers of science, some of us are clinicians, we see patients, many of us are patients ourselves in different scenarios and at different times in our lives. And we can just challenge, we can say, well, what, on what basis is this decision being made? And certainly kind of as a clinician, my awakening was sort of, I can't believe that this hasn't been thought of. I can't believe there isn't evidence about this. So it is, I think the first thing we can all do is just keep asking the question and then be surprised by how often questions about inclusion have not been accounted for. And please get in touch with us. If this has resonated with you, we'd be delighted to hear from you, whoever you are, whatever your background, whatever your skills, whether it's just to raise your support, it would be very welcome.
Brilliant. Would anyone else like to add a last thought on that question? If not, we'll move to towards the end.
Okay, well, it's the close of today's webinar. I can't believe it. It whipped past and there was just so much energy and it was wonderful to hear from so many different people. We wondered if we were spoiling ourselves by cramming too much talent onto the call, but it's worked out, so that's been fantastic. So thank you so much to our fantastic panel of speakers. The Message Project is so grateful for your expertise and contributions. And to you, our audience, for joining us to learn more about improving research inclusivity and also research rigor. The Message Framework, as I said, available on our website, which you can follow the link on the slide now. And this framework will grow and sustain with your ongoing commitment and interest. So I'll say it again, please get in touch if you'd like to partner with us or learn more about our next projects. So those are projects that have come out of Message, which have exposed more gaps and intersectional projects which we're working on for greater research inclusion. And before we close, I'd like to extend my thanks to my colleagues at the George Institute for Global Health, especially Alice Witt, Alex Bentley, and Celestine Donovan Bradley, who have worked just so hard to make this webinar a real success. So thank you all.